Takes. Hello, everyone. Hopefully we are live. I'm going to just look over here on Instagram to confirm. I apologize that we were not right on in time. Of course, you plan ahead, and sometimes the best laid plans don't go well. I would love it if somebody could let me know that we're live so that I know. That would be awesome. But I have Dr. Michael Schwartz with me here. We are friends and colleagues, and he is my lipedema surgeon. And so I asked him to join today. I have asked all of you some great questions and got some great questions back in return. But I just want to start by welcoming Dr. Michael Schwartz, world-renowned lipedema surgeon in Pasadena, California. And also say that I think I speak for everyone when I say that our hearts are with everybody in your hometown of Pasadena and the surrounding area of Altadena.
Thank you. Yeah, thank you. It's been crazy, but
yes.
It's so crazy.
Yes. Well, tell us a little bit about yourself, Dr. Schwartz. So how long have you been doing lipedema surgeries?
I've been doing lipedema surgery for quite some time. Even before I knew about lipedema, I had patients whom I remember had large amounts of fat that I hadn't seen before in the lower body, legs primarily. And so to answer the question, probably 15 years. I've been keeping track of patients. One of these questions is how many surgeries have I performed for lipedema? So I'm keeping some data, and I'm going to publish it very soon. The intent was to look at hemoglobin levels after large volume liposuction, because the criteria that are out there for liposuction volumes really don't apply to lipedema patients. So in answer to that question, at least since I've been keeping track, in June of 2017, I've done 640 cases.
Wow.
And so many of those are, those are surgeries. And so it's not 640 patients, but it's 640 surgeries. Okay. And prior to that, probably for 10 years before that.
Wow. And did you know that they were lipedema patients initially, or you just started seeing it and knew something was wrong?
Initially, I didn't know. No, I was not familiar with it. And as most of you have probably experienced, a lot of doctors don't know about lipedema. It's becoming more well known now, fortunately. But initially, a lot of medical people just don't know about it, which is really strange. For some reason, vascular surgeons or vascular medicine doctors knew about lipedema, and maybe dermatologists, but otherwise it was pretty obscure in the medical community.
Yeah, that was my experience. So I have May-Thurner syndrome, so I have compression of the right iliac vasculature, and my vascular surgeon knew. So I think that's right. I think a lot of vein surgeons know, although I know some women try and get diagnosed with vein specialist and can't. So I'm glad that it's becoming more prominent. And I think the more we talk about it, the more women will find out. So, well, we asked people to submit questions ahead of time, and I have a whole list here. So to respect your time, I'm going to get rocking and rolling. And while you're answering, I'm going to look away and tell people we are live, because I knew that we were a little bit late getting online. There was an issue with technical difficulties on my end. I tested it out a zillion times and something went wrong. But the first question is your thoughts on GLP-1 medications before and after surgery to control inflammation and help with weight loss.
So first of all, I don't know that there's any data about controlling inflammation, although, and first of all, these drugs are relatively new, out, in the last 2 to 3 years. I'm not sure exactly which, but 2 to 3 years. And they're pretty miraculous. People who have not been able to lose weight in the past are now losing large amounts of weight. And not only does it curb appetite and work as an appetite suppressant, but apparently also works. And these were initially drugs for diabetes, so they were reducing blood sugar. So it does reduce your blood sugar, reduces hemoglobin A1C, which is a blood test that we do and internists do to get a look at your blood sugar levels over the past 3 months. So it's not just a spot spot blood glucose. Anyway, it lowers hemoglobin A1C. People are losing weight. And not only weight loss, but it curbs addictive behavior, smoking, drinking, gambling even. So they're pretty miraculous, and new things are popping up all the time. However, the long-term, and so in answer to the question, is this good for lipedema, for women with lipedema? I think that nutritional control is a better option. It's healthier. There's some questions about these drugs. They do work, but there's some questions, and some research has been done to show that a significant part of the weight loss might be muscle or bone loss. And there have been studies that have shown up to 25% of the weight loss can be muscle, and that's muscle that it takes years to build, and you're not going to gain that back. So if you need to remain active if you're on these drugs, and exercise and do some light weights and things like that to maintain muscle and bone mass. And so I think the jury's out. The drugs have been out. They're passed by the FDA, obviously. They're extremely popular, but there's no long-term data about the long-term side effects of these. So I think the jury's out. However, in regards to lipedema, it's really difficult to lose lipedema fat. Numerous patients who have had bariatric surgery, they've been on all kinds of diets, they've been shamed their whole lives, they've been told they're just stop eating. I have many people tell me they eat 500 calories a day and they can't lose weight. So, and even with bariatric surgery, it's common for lipedema patients to lose non-lipedema fat, like in the torso, although you can have lipedema in the torso, obviously, and breasts and back, flanks, abdomen. But bariatric surgery has been successful except the buttocks and legs and arms. So a lot of patients I've seen have lost 50 to 100 pounds, but they still have disproportionately larger lower body, legs, buttocks areas. So I think the jury's out. I think it has a place in lipedema. Sorry, I'm going on too long. For people that can't lose weight otherwise, but I think talking to Bonnie about nutrition is always a better, Bonnie or whomever, is a better way to go than to just jump to these drugs.
Because I guess my thinking is they can be helpful as well, and I have many patients that use them and have great success. But at the end of the day, you still have to eat right, even on these medications.
Yes.
I guess a question that I have after hearing your answer there is, if somebody has a substantial amount of weight to lose, does it help to get some of that weight off prior to going into surgery so that it makes the lipedema reduction easier because you can see that tissue more defined?
I don't think it makes the surgery easier. And with liposuction in general, it's always helpful to lose weight if you can prior to surgery. So yeah, the answer is yes, but it's really difficult to do, even in non-lipedema patients for liposuction. And the nice thing is about liposuction is you're just suctioning the fat in the fat compartment under the skin, between the skin and the muscle. So you can't remove visceral fat that surrounds the organs in the abdomen, for example. That you need to lose that with diet and exercise or these medications. But it's always beneficial, but it's probably not practical. Most of the patients I see have already tried every which way to lose weight. And you're removing the subcutaneous fat, which another question on here is what does that weigh? And fat does weigh 2.2 liters per pound, 2.2 pounds per liter. So for example, if we remove 10 liters, you really should expect to lose 22 pounds. And we see people do that. We also see people come back who weigh exactly the same after we've taken 10 liters out and say, well, my weight hasn't changed at all. Well, I'm sorry to say that you've gained weight if that's the case. But, and there is a direct correlation. So if we take out a liter of fat, you should lose a couple of pounds.
Okay. Yeah, I remember seeing that question on here. The next question is, what are your top 3 things patients can do to prepare for lipedema reduction surgery?
I think, I don't know if I have 3 things. I think you should be in the best possible health, avoid alcohol for a week prior to surgery, avoid NSAIDs, Advil, any ibuprofen, Aleve, aspirin for a good 2 weeks. Interestingly, if you're on the GLP-1 medications, you need to be off those now for 2 weeks because they delay gastric emptying. So it's a little bit dangerous to have anesthesia, or whether you're awake or asleep. you could have reflux from your stomach because the contents aren't emptying, and you can aspirate. That's very dangerous in surgery. So normally in surgery, you have to have nothing by mouth for 12 hours beforehand. But with the GLP-1 drugs, you really need to be off for 2 weeks.
Okay. Awesome.
Oh, and so, general good health, eat well, avoid alcohol, cigarettes or any tobacco is a big no-no. But there's nothing specific that I tell people for lipedema surgery. Most patients have already tried everything, and most are on low simple carb or low carb diets, avoiding simple carbs. And so those are the important things.
I would say actually that I think working in the lipedema population, I have some of the most in tune and smartest patients that I've ever had, because they have tried everything with regard to diet, myself included. I mean, I was a yo-yo dieter for years and years. And to your point, I think that that's one thing, and this, I'm kind of jumping ahead here, but that's one thing in the lipedema community that I see is avoiding carbohydrates totally. And that does work for some people anecdotally. I think long-term, we just don't know what the research is on the gut and the microbiome. But I think I wish that we would differentiate between carbohydrates and fiber, because there really is a difference in the way that, one, that presents in our system metabolically, but two, in the health benefits from different types of carbs. So I won't go into that too much right now, but actually that's the next question.
Complex carbs, you can address this better than I, but they're good for you.
Yeah, that's the next question. How do I, does how I eat really impact lipedema progression? And so I don't know if you want to answer that first, and then I'll chime in and I'll look over here at some questions.
I think you can answer it. Why don't you answer that first?
Okay, yeah. I would say yes, it does impact progression, because we want to limit the amount of inflammation. And so really paying attention to how much we spike our insulin and concentrating on gut health and focusing on foods that are fiber rich and have protein to them will help to stabilize blood sugar. But what I often see is that women incorrectly think that, doing something 1 time or 2 times is going to progress lipedema. This isn't an overnight sensation. It's something that kind of happens over a period of time. So I think that paying attention to what we eat just to manage, one, our non-lippy fat, but also to lower inflammation really makes a difference in progressing. That's kind of what I've seen.
And so again, it's not really clear what the etiology of lipedema is, what causes it. There is a genetic aspect. It's autosomal dominant. You can get lipedema from either your father or your mother. Right. It doesn't express in men cruelly. It's limited to women somehow, but it is thought to be hormone sensitive or hormone dependent, and people see spikes around hormonal events like hysterectomy. So it's very common for people to come in and say, I had a hysterectomy and gained 20 pounds afterwards, and this lipedema is really progressing. Around menopause, for example, it starts just after puberty. So it is definitely hormone dependent and diet dependent. Carbs are inflammatory. So the simple carbs, sugars and pastas, and white breads and alcohol, they're inflammatory.
Yeah. I would say, I mean, my legs were always bigger. I was referred to as thunder thighs, but definitely I had a hysterectomy in 2018. And then I had, I went through menopause shortly thereafter, and man, did everything change. And I had already lost 170 pounds. But as you know, from being intimately aware of what my tissue looked like, there was a lot of lipedema there that really progressed for me at menopause. So I think we're all different, but I think the hormonal shifts are definitely indicative of the progression for sure. Yes. And the next question is, can you lose lipedema fat without surgery to remove it?
Well, possibly. So back to the GLP-1 drugs, I've seen people lose lipedema fat on these GLP-1s, and that's not supposed to happen, but it's happening. So in that sense, you can. Some people are successful with diet and exercise, nutritional changes, losing lipedema fat, but it's rare. It's more common to lose your non-lipedema fat and not be able to lose lipedema fat.
Mm-hmm. Okay. Oh yeah, and we were going to talk about this earlier when I introduced you, and I forgot to address it early on. So a question is, are you board certified plastic surgeon? And what is the difference in training from a dermatologic surgeon versus cosmetic and plastic surgeon?
Yeah, that's an interesting question. It's a good question. There are many different ways to achieve training, and I personally am boarded in 3 different specialties. Those are otolaryngology, head and neck surgery, facial plastic and reconstructive surgery, and cosmetic surgery. So not the American Board of Plastic Surgery. I share a call with plastic surgeons. I think my training is as good or superior to any training that anyone's had. My experience is vast, so I feel really great about the training I had. And when you hear from people that, I hate to say it, but it's mostly the plastic surgery community, their attitude is that we're the only ones that should be doing everything. Nobody else can do anything. That's not true. And in regard to dermatology, it's actually a dermatologist, Jeffrey Klein in California, who is also a pharmacist, who did the original studies on tumescent anesthetic solution, which is the numbing solution we use with all liposuction. I use it with every surgery, with breast surgery, liposuction, facelifts. So you mix lidocaine and epinephrine into bags of IV fluid, and we inject these into the fat compartment or whatever area we're working on, and the lidocaine numbs the area, the fluid hydrodissects the area, and the epinephrine constricts blood vessels and minimizes bleeding and bruising. And so that was the dermatologist who did those studies and determined the maximum safe doses of lidocaine in tumescent fluid. And he, in particular, does all his liposuction under straight local anesthesia in his office.
Okay.
And so, in answer to that, there are dermatologists who are really good at liposuction, yes. And so I don't think specialty is really determinant as to who can do what. You need to talk to your doctor, look at results, look at before and after pictures, see what their experience is, and that's what's really important.
I think that was another question, was about skin excisions. Can a dermatologic surgeon do skin excisions? Trying to find the question, but there was something to that effect. But since we're here, can you touch on that? Does that matter?
They can. I mean, they possibly can if they're trained to do that. Most don't. I have to say, most don't.
Okay.
You know, the dermatologists doing lipedema surgery have other surgeons associated with them who do the skin removal surgery. I personally have great training with skin removal in arms, back, abdomen, legs, so I do that myself. And there's a question also about timing and staging. We can talk about that later also. But okay. Some do. I also have hospital privileges to do that, so that's an important thing. You want to see if your surgeon has hospital privileges to do the things that they're doing.
Okay. All right. Yes, there are questions about that further down. I tried to put them in order here.
That's okay.
Okay, the next question is lipedema reduction surgery possible on ladies in their 70s if they are in good health?
Yes. Yes, and I have quite a few patients in their 70s.
Okay.
I would say 80s, probably you don't want to do it at that point. But in the 70s, if you're healthy, yes, we do that quite a bit.
Okay, perfect. And when are the final results after having lipedema reduction surgery going to be seen? I think what this person was asking is it 6 months? Is it a year? When should they say these are the final results and evaluate whether or not they're happy?
I think a year definitely, but probably 6 months. You have a pretty good idea. I know that the skin tightening that occurs does so between 3 and 6 months post-op. So in the first 3 months, you're not going to see skin tightening. You'll be smaller and you might see some contraction of skin, but the new collagen forms and the skin actually tightens up between 3 and 6 months, and sometimes 6 months plus. So at a year, things are not going to change, that's for sure. But prior to that, you might have some swelling that would resolve still, depending on the area also that's being treated.
Okay, so what I'm hearing is a year out from surgery, that's kind of where you're going to land probably, unless you start doing significant changes to maybe weight training or something. Is that right?
Yes, and we, I like to stage the skin removal in the legs, and I like people to wait at least 6 months after the removal of fat to see how much skin contraction we're getting, and to see that the swelling is gone, so that we can make an accurate assessment.
Yeah, I think that was a question. So somebody asked, I know it's in here.
Yeah,
so I'll address it now. Do you like to do the skin excisions with high volume surgery, or do you prefer to wait, and why?
That's a good question, and I have a personal preference from experience. So,
okay,
right, we 99% of the time in the arms we remove skin at the same time. The arm is a smaller cylinder, so to speak, compared to the leg, and you can suction the arm. And when we do that, we suction the arm circumferentially, the whole arm, usually the upper and lower arm. We remove skin from the underarm area to just below the elbow, sometimes even to the wrist. And the nice thing about doing that at the same time is that it acts as its own auto compression. So, if we don't do that, so in a few cases where there was a large amount of fat in the arms, 2 to 3 liters in each arm, which is really a lot of fat in the arms, I've staged it and said, let's remove the fat and then see what we're left with, so we can more accurately remove skin. In the abdomen, we routinely do lipoabdominoplasty, which is a tummy tuck with liposuction, and that is very successful. In the legs, I like to stage the legs. I like to stage the legs for both liposuction and skin removal. And the reason for that is if you treat the legs circumferentially, they tend to stay swollen for much longer. So, and I did that early on, and I stopped doing it. And so even in smaller women with lipedema, where you might think, well, why don't we just do the whole leg at one time? It creates swelling for a much longer period. And so I like to treat the front or anterior half of the leg from the groin to the ankle. And then we usually put 2 months in between these surgeries. If anyone wants to know what my protocol is, I can go into that. But we usually put 2 months between these. And the reason for doing the front and then the back separately is that it preserves the venous and lymphatic outflow in the half that we're not doing. So you get better drainage and you're more responsive to lymphatic massage, and the swelling subsides quicker.
Okay.
And then after doing so sometimes and I start with the front of the leg. I usually can get more volume out of the front and work all the way around to the back. And so there's less to do when we do the back of the leg. In some cases, we can do the back of the leg and remove skin at the same time. But in most cases, we do the front of the legs and the back of the legs a few months later, and then wait 6 months from that second surgery to assess the skin and see whether it even needs to come out. Sometimes we're surprised, and we're pleasantly surprised, and the skin contracts. And I've had that happen even in a 70-year-old patient, where I was very surprised to see how much skin contraction they got.
Right. I know that was my personal experience, because you took a look at my legs after 170-pound weight loss and said, ooh, we're going to need skin excisions. And so we didn't do body tight, and we'll get into that, I guess, here in just a minute, since I'm kind of jumping ahead. But we didn't do body tight when we did the front of my legs, but then they actually retracted better than expected. So we did body tight on the back and on my arms, and my arms were quite problematic with lipedema. And we thought I would need a skin excision on my arms, but doing the body tight worked for me. And I know that was a question here can you explain the difference between body tight and Rejuvion, if I'm saying that right, and J-plasma, and what the benefits are for use of each?
Yeah, so J-plasma and Renuvion are the same thing. They renamed it Renuvion after it was originally J-plasma. And that is it's a plasma kind of heating up the inner. It's at the end of a rod, and you do the liposuction, and then you use the same incisions and heat up the undersurface of the skin. So basically, all these skin tightening modalities are means of heating up the skin, which helps form new collagen and tighten the skin. I thought that was a little. I think the first person in Los Angeles to have J-plasma, and I used it. It works. It doesn't work for skin resurfacing. They said we could do that at first. That was a big mistake. But it does work for skin tightening. However, you're heating up the skin, and there's not much. You're using an external digital thermometer to try to assess the skin temperature.
Oh,
Body tight is a bipolar, meaning it's like a tweezer with a little paddle on each one. One goes under the skin, one's over the skin. There's a thermometer in each one of those. So
okay.
we set parameters for the internal and external skin temperature, and that just activates and heats up the skin from the inside and the outside with constant temperature monitoring. So it's more accurate, I think. So
Okay.
any means of heating up the skin, but you want to do it safely, will help create new collagen and skin tightening.
Is the J plasma helium or something
It
like
is. It's yeah, that it is. It's a helium gas that's kind of ignited.
that? Okay. And is there one that's better than the other, or are they about equal? Why do you choose body tight? You think it's more precise with the pads on?
I think it's more precise. I
Okay.
still have my Renuvion.
Okay.
I just don't use it. I don't mean to badmouth Renuvion. Some people really like it.
Yeah,
Somebody just sent me photos of Renuvion treatment in the arm. It looked really good. I don't
sure.
think one's better than the other. I think it really depends on each person and what your skin's going to do in response to this.
Okay, fair enough. The next question is kind of about skin resurfacing, and I actually have a firsthand experience with this, but this is with cavitation for smoothing out or removing lipedema fat.
I'm not familiar with that. What do you mean skin resurfacing?
So just making the skin more smooth, making the dimply appearance more smooth. Do you feel cavitation is good for that? And then the second part of the question is, can that remove some of the lipedema fat? I'm assuming by kind of breaking it down, because there is a little bit of a manual component to it as well.
I'm actually not familiar with that specific treatment that you're referring to, although there are different things for cellulite, which is skin fibers stuck to the fat, which creates a dimpling. In lipedema, it might be a little different because there are lumpy fat deposits that create that cellulitic look or uneven surface also. So things that, something that works really well for that is called endermology. It's just you wear like a light leotard. It's two rollers with a suction in the middle, and it lifts up and rolls the skin. So that breaks up those attachments. This cavitation probably does the same thing. We have something called
Morpheus. Is it Morpheus?
I don't have Morpheus, no. But I have Ultra Shape, I believe. Ultra Shape, which is two rollers with suction and heat. So that heats up the skin and suctions and rolls it. But those aren't really means of removing lipedema fat. They don't penetrate that much.
Right.
And you may be getting a few millimeters beneath the skin, but you're not getting inches below the skin, which is where the fat is.
Yeah, so maybe it's a modality to be used in addition to. I know that there was going to
be. It wouldn't hurt. Yeah, it wouldn't hurt. It may help with skin contour. Yeah.
Okay, I know there was going to be a study done on this in particular with lipedema. I have firsthand experience with cavitation. I did it after my leg surgeries, hoping to sort of smooth out some of the dimpling where my hip meets my waist buttocks area, and it was quite costly to do it. I think I went twice a week, maybe for, I don't know, 3 months. And I mean, everyone's different, right? But for me, it made absolutely no difference. I took pictures every week, and even the technician was like, wow, there's really just no difference. And I don't know if that is dependent on somebody's level of fibrosis or just their tissue, but I see folks say that they have some benefit from it, but I guess it's one of those, who knows, right? It could not.
I think endermology, which is inexpensive, it's simple, not at all dangerous, and I think it works really well. It's just not permanent, so you need to maintain it and generally do it a few times in the first month and then monthly to keep it up. But it's kind of like a relaxing deep tissue massage, so it's pleasant.
Okay. And is that done at a plastic surgeon's office or a med spa type of situation?
You can find them in different places. I have the Ultra Shape now. I used to have endermology, but we have Ultra Shape now, which is the same thing with heat. So we use that.
Okay.
All right. And so I don't know where you'd have to look around for that. I don't know.
Okay. And you already answered the next question, so I'm going to skip that one. But after lipedema reduction surgery, does a patient get lipedema growth in untreated areas? And if so, why?
I think the answer is yes, from experience. Definitely. We have patients come back after a year and we've done, let's say we've done all the involved areas, the arms, back, flanks, abdomen, legs, and they say their breasts have increased by 2+ cup sizes, which is really unusual. And, as women age, the glandular breast tissue turns to fat. So it makes sense that there's fat in the breasts, and lipedema, unfortunately, can increase. So, and likewise, if you spot treat or just treat legs, some people report that their arms are getting larger. I don't think anyone knows why. There's really no, the only other time you get compensatory fat growth like that with, or grow new fat is in type 1 diabetics. So it's unusual, but it does happen with lipedema. And I don't think anybody knows why.
Did you tell me that when we have areas treated, that because it's also removing normal fat, that if we put on weight, it may appear that we're gaining weight in other areas just by nature of having some of those fat cells removed in that specific area that was treated?
Well, when I do surgery, I take out all the fat that will come out in that area. We have to leave a little layer under the skin or you get really severe contour deformities. So I take out all the fat that will come out in an area. So if you gain weight, in general with liposuction, if it's done correctly, you'll gain it elsewhere, and you'll gain a little bit in the areas that are treated, but you shouldn't gain a lot of weight in the areas that were treated, because the surgery also, 6 months later, let's say the swelling's gone and your tissues are soft, but there's scar tissue in there and that matrix of connective tissue. So I think that helps prevent new fat growth also.
Okay. I mean, I've definitely noticed that my bust size and my rear size are a little bit more solid post-surgery.
Really?
So that's where the growth has been. Okay. And this was the question about body type. So I just want to make sure I answered it. Who's a good candidate for body type? And what are outcome differences you have seen between radio frequency, laser, plasma treatment? And are there specific areas where one might be more effective than the other?
That's a good question. I don't think these modalities work very well on the legs, for a number of reasons. The inner thigh skin is really thinner than the rest of the leg skin, so it's really difficult. And if you heat up the inner thigh skin that's been emptied out already of fat, it may be too thin and gets kind of indurated or wrinkly. It might help a bit, but I don't generally do it a lot in the legs. Some people request it, and sometimes we do it. Or if I think it's we're on the fence and they may need skin removal or may not, and this would help, we do it. I do it in the arms quite a bit. I think it really helps in the arms, and people who are just on the borderline of maybe needing skin excision, because that's a long incision in the arm and it's a bigger deal to have a brachioplasty. So it's worthwhile to try it there. I've done it in all areas of the body, really. It's just only so effective. It's not miraculous. Okay. Other than somebody did just send us photos, as I said, of their arms after Renuvion, and it looks great. So that might happen. Sometimes it will be effective. So yeah. I mean, it adds a little cost and time to the surgery, but other than that, there's no downside to doing it.
Yeah. I mean, I have lymphedema as well. And as you recall, I had sort of the bat wing hanging there. Right. It would wave when I didn't want it to. And using the body type did really work for me, even being in my 50s. But I guess it just, I suppose it's based on somebody's skin laxity and just their particular body.
Yeah. I think it's your own skin quality and thickness and elasticity and how it's going to respond to the heat.
This wasn't on here, but I'm just curious because it's so prominent in the lipedema community. If somebody has EDS, the hypermobile EDS, and they have more skin laxity, does that make these modalities less effective or not necessarily?
I think not necessarily. Okay. I think it's just a function of how much skin laxity you have. Okay,
fair enough. Are there benefits to twilight over general anesthesia, and will you use twilight if preferred? by the patient?
We do if requested, but I'll just say this: I've done liposuction under local anesthesia. I do some touch-ups under local. I do some small areas under local. Local meaning the local tumescent with some sedation, either oral or IV sedation. In California, if you're unconscious, it's considered general anesthesia. I think for lipedema surgery, for a number of reasons, it's better to be asleep or unconscious. And you can have IV sedation and be unconscious, but then the issue is with the airway. So I always have an anesthesiologist. The anesthesiologists don't like to have people asleep without any kind of airway control or protection, especially in prone position if you're on your stomach, because then you don't get access to the airway.
Okay.
So we use different things with, and so even with our general, we use IV propofol, which is a great IV drug when used correctly, and it has antiemetic effects, decreases nausea, vomiting, and it puts people to sleep. The minute you stop the drip, they wake up, they feel good afterwards. And again, much less nausea. We really avoid inhalation gases and narcotics during surgery because those make you sick, and that's what makes you vomit after surgery. So I know there are lipedema surgeons doing surgery under local or what they call twilight or what they call IV sedation, and I've seen patients from other places that have had it done that way, and a lot of them describe it as extremely painful and torturous. So here are the reasons I like to have people to sleep. One, it's more comfortable. It's not painful. It's very safe. We've never had an anesthesia complication, knock wood. And so it's very safe. And if someone's awake, and so we're limited in surgery by the volume that we can remove at one time and by the amount of lidocaine we can give you in the tumescent fluid. And if you're awake, we need to use more lidocaine. We need to take a much longer time to get an area numb. And in a lot of cases, it's hard to numb the lining of the muscle called the fascia. It's really hard to numb that. So, people tend to be uncomfortable even with all those precautions and steps. And it's just much easier and more comfortable to be asleep. The other thing is I can do more in one surgery. And these surgeries are staged, and lipedema ladies are having more than one surgery usually. So if we're doing it under local, we're going to have to do less volume, use more lidocaine, and you're going to have more surgeries. So for those reasons, I like people to be asleep.
Yeah. I think that's an important thing when you're traveling too. The less surgeries can be beneficial, right?
Yes.
Cost-wise. Okay. Can lymphedema make lipedema progress faster? Why is it that the further I am away from menopause, my lipedema growth is getting worse? That was the next question.
Oh, well, I think it goes back to, it's somewhat hormone dependent, and we don't really know how. It's thought to be estrogen dependent to a degree. I don't know why the further away from menopause it would get worse. I don't think anybody knows the answer to that. And I've published a couple of papers with Karen Herbst, and she and Sarah Al-Gadban have done a lot of research on lipedema, and they documented that you have leaky blood vessels as part of the etiology of lipedema, so it allows fluid and into the interstitial area, and there's abnormal fat growth. We know that, but we just don't have that information.
That's what I was thinking too. As we go through menopause and we lose estrogen, estrogen helps to provide protein homeostasis and maintain musculature and where we actually put on our adipose tissue. So I think that when somebody's getting further away from postmenopause, there's usually a breakdown in even more muscle tissue, and we typically become less active, although that's not always the case, especially nowadays. And maybe that's one reason just putting on more weight in and of itself kind of can perpetuate that systemic inflammation. And maybe that's another issue. I'm not sure, but that's just my brain thinking. Okay. And then sort of getting to some of the newer questions here. Okay, you kind of already answered that one, I think, about the cases where somebody wants skin removal. Realistically, what is typically expected in terms of scar tissue buildup after lipedema debulking surgery? What complications or benefits can this have?
Well, you shouldn't build up a lot of scar tissue. That just shouldn't happen. I mean, you remove fat, and um, uh, you just shouldn't be building up. I mean, there's a certain amount of scarring that occurs in the fat compartment, but it's not going to be a large amount of scar tissue.
Okay. I will say with we can talk about my surgeries here for just a minute, but I had skin excision on my legs in June of 2023. So that was my last surgery. And it was really interesting how I was expecting to have sort of a raised scar from having back surgery before and thinking it would kind of be the same. My incision now is completely flat. If somebody was just to feel my leg, they would have no evidence that I had, skin excision. One of the things that I did, and this wasn't on the question, but I'm just sharing to share, is that I did broadband light therapy on my scars 3 months post-surgery, and it really did help. I mean, the scars are completely flat and really pretty hard to see.
That's great.
I was very concerned.
Red and blue light therapy is helpful for the skin and for scars. Yes.
Yeah. I think it's hard for so many lipedema women because we live in these bodies that we don't love for so long. And I'm going a little bit off our script here, but just to be open and honest. And we have these surgeries and we know that we're not going to come out looking like supermodels, but there is a want and a desire to still get the best results that we can. Yes. And scar placement and these scars are still something to consider. So I think things that can help move those scars along are always helpful. So I just wanted to share that. But what are your thoughts on that? Because I know that this is varying drastically among different surgeons, whether or not lipedema surgery can be both debulking, but also have sort of an aesthetic finish as well.
Well, I think that's really important. I mean, everybody wants to look better. I don't think you can just take out large volumes of fat and not pay attention to the cosmetic aspect. And I'm very conscious of that. So, I tell people, for example, who have larger legs that it's a trade-off. I mean, we're debulking the lipedema fat in the legs and kind of deflating the leg of fat. But that means the skin may not react so positively, and you may get more wrinkly or contour deformities of the skin. And that's why we sometimes do thigh-plasty and remove that skin, or the body tight or other skin tightening modalities. But it's a trade-off to a degree. But I think the cosmetic aspect is as important as the lipedema aspect. So we want people to be functionally improved and cosmetically improved, both. I think they're both important.
Yes, I appreciate
the functional part with lipedema is probably more important because you have pain and mobility issues and joint issues, and so we want to remove that, but you don't want to make somebody look worse.
Yeah. I think that's a question that I get asked this question quite a bit when people hear, I had my lipedema reduction surgeries after losing 170 pounds. And kind of the lipedema progressed at menopause. And I had the surgeries because my legs were so heavy and uncomfortable. And I will say after having the surgeries, my mobility is night and day. I mean, my legs used to just ache and I don't have that heaviness and that achiness anymore. I think for so many of us, we don't know what we don't know, and that we just think that everybody has heavy legs. But my gosh, it's been so much better to have lighter legs and be able to move through the world lighter on all aspects of that. So thanks to you, that's appreciated. Something you just said that I was going to touch on, but my menopausal brain forgot. So, okay. So now kind of a hard question from a client or a lippy lady. I am struggling to choose my surgeon because I had a fantastic consultation with a surgeon who feels like the right fit for me. But when I talked separately to the assistant at the end of my appointment, that person gave me medical advice that was drastically different from the surgeon and said than what the surgeon had said. Do you have any suggestions for how to handle this kind of situation? And how would you suggest weighing this kind of discrepancy when considering a surgeon? There's several pieces here, so bear with me. One area where the surgeon and assistant were completely at odds was about post-surgical pain. The surgeon talked about how the pain was manageable with medications, and the assistant said, disregard what the surgeon said. My body would feel like it was burning and on fire for up to 6 months if I had skin tightening. What do you typically see in terms of pain with debulking surgeries and skin tightening?
That's a lot of questions.
Yes.
You know, I would say if that's the case, that you should just talk to the surgeon. If it's my office, I'm happy to talk to whoever you are. I find that you know, I don't want to dispute this, but sometimes people infer things inaccurately. Sometimes things are said, and who knows? I don't know. But I would always say, if you like the surgeon, talk to the surgeon. And I know I'm happy to talk to patients. I give people my cell phone number. I'm always accessible. If it's, you know, if it's me, give me a call, and I'm happy to talk to you. That's unusual that an assistant would say disregard what the surgeon told you. I just don't know anybody that would say that. So I would just say reach out to the doctor.
Okay.
It's very, very simple. And if it's a communication issue, it should be addressed. And we're very transparent. I would, you know, if that's the case, I would talk to the patient, talk to the assistant, and see what is the real story. Regarding pain, we give everybody pain medicine, and I tell everybody, at least on the day of surgery, that you may wake up with some burning in your legs. So we're going to give you medicine in recovery. It usually subsides after a few hours on that day, but you're going to have pain for a while, and we give everybody usually Vicodin or Percocet or Tramadol if they can't tolerate those. And people have different pain tolerances.
Right.
I did surgery on a woman last week who had a really large abdominal excess of fat and skin, and we did a really large lipoabdominoplasty, and she came in the next day and said, I'm not taking pain medicine. I took a couple of Tylenol. So that's really unusual. I mean, I give everybody at least 30 Vicodin, and she didn't take any, and that's very unusual. And then I have people who say, you know, this is killing me. What are we going to do? And we address that. But and then, you know, you're going to be sore for a while. If we do the legs, when you get up and walk around, the first few steps are going to be sore for a while. I've had surgery myself, and I tolerate the pain pretty well, but it hurts every time I move.
Right.
And with lipedema, it's the same thing. I know swelling peaks really from 2 to 4 weeks. Swelling contributes to the pain. So there's going to be some pain involved, but it's manageable. I don't know that, I wouldn't describe it as you're on fire for 6 months. I've never heard that before. So, but again, I would be happy to talk to whoever that would be, if that's my office, and straighten it out. And I would urge you to talk to your doctor, whoever that might be.
Sounds good. I think I shared with you, I had a little bit of skin sensation, kind of sunburn feeling from the body tight when we did my arms.
Mm-hmm.
And one of the things I did, and I said, I don't know if the occupational therapists listening are going to cringe, but I used aloe vera gel to take away sort of the surface burn. And that
Mm-hmm.
was so helpful. And it did get to the point at one point where I actually put aloe vera over my compression, my Mirena, and it just made all the difference. It made it bearable. So if somebody experiences that, for me, it was like a sunburn.
Oh, okay.
So,
you know.
But I only had that where I had the body tight. So I don't know if that's, you know, just a side effect, or if that was just me, just sharing to share. And we talked about the anesthesia. I'm just making sure I got all the questions, because some of them got a little bit out of control, out of the sequence here. I think you answered everything. Let me just log on and see if there's anything online. Somebody says there's no live showing up on your page or his. I've been here for an hour, but I show we're live and people are here. So that's really interesting.
Can people comment on the side if they're there? Can they type in questions?
Yes. And let me go to Facebook too and see if there's any additional questions. That's really strange. I guess I'm showing that we're live, so, and I see people on. So let me just go, sorry, take a second here to log into Facebook too.
There are no comments on my computer.
Yeah.
I sure hope everybody heard this. If not, we're going to do it again.
They did, because I can see
Okay.
them on here. So I definitely know that there are people listening. Yeah, well, one last question is, are we going to see you at FDRS?
Well, unfortunately, not this year. I'll just. Oh, yes, it says you're live on Facebook.
Yep. And
Okay.
yep.
Great.
Good.
I'm not going to make it this year. I previously scheduled hip replacement surgery for myself, so I have to go be a patient, and that was the only date. It's a date in March, and it's close to the meeting. That was as soon as I could get it before I knew about the meeting date. I thought the meeting might be before that date, but it's not. It's after. So unfortunately, I'm going to miss it this year, but I'll be back next year. I just have overuse hip joints from bike riding and sports and things. So I already had one hip replacement about 5 years ago, and it's great. And I thought I would never need to do the other one. I have to do it. So
Here you are. The joys of aging.
I'm going to have to be the patient. Yeah.
Yeah. One question is, sorry, and I'm like, okay, what questions can we answer before we go, before I let you go, is does your office take insurance, or do you work with insurance?
Yes, we do. People do pay for surgery up front, but we have a woman named Diane who's remote, but she is a great insurance biller coordinator, and she helps people with insurance and can help them submit paperwork, and she does coding and so forth, and appeals and everything. And we've had really good success getting reimbursed in a lot of cases.
Yes. So I'll just share my personal story too. So I had 4 surgeries. I had the front of legs, back of legs, my back, and then my leg skin excisions done. And the first 3 surgeries, I got all pre-approved with TRICARE. I have TRICARE East, and they were all pre-approved. I got you as an in-network provider, and they were all pre-approved, and I got about an 85% reimbursement. I am having to kind of go back and have a charge allowance review for the skin excision, but just a plug for Diana. She is great. She has helped me through the process, and I got approved on the first try. I mean, so no problems with that.
It's somewhat dependent on the insurance companies, and Christina, who works with me, knows more about that as to which ones have been paying and which ones haven't. There've been some. We had one patient lead a class action suit against Blue Cross of California, and that was successful. It's still difficult because they'll pre-approve something and then they just refuse to pay for a year or so they can, I don't know what. If they refuse everybody for a year, they get to invest all that money. But so it's not fair. It's a big job to get reimbursed, but it happens.
Yes, it's really frustrating, but well, I can't say enough. Thank you so much for joining me.
Yeah, my pleasure.
I will put up email addresses here if people want to contact. I know Christina's your coordinator, so Christina there,
yes.
Dr. Schwartz @gmail.com, and my email's there too if somebody wants to reach out to me. I had 4 surgeries with Dr. Schwartz, 3 in 2023 and 1 in 2024, my skin excision in 2024. And I don't not share about my surgeries. It's just not my main wheelhouse. But if you have questions, I'm certainly able to answer, even if you have a different surgeon. If I can help you in any way or support you, I'm happy to. But I had amazing results with my surgery. That said, I realize surgery isn't for everybody, and it's something you should definitely consider. But yeah, I had great results. And Tommy says, hey, Dr. Schwartz, thank you for all the information. I had 5 surgeries in 2018. I'm still struggling with some fibrosis in my legs. What is the best treatment I could use for that?
I think massage is the best thing, or massage and or what I was mentioning, endermology, which is the 2 rollers with suction, or Ultra Shape, or I think it's not Ultra Shape was a fat removal device. It's called Vela Shape, VELA Shape, which is the rollers with suction and heat. I think that would help the most, and massage. I'm not sure what else would do that.
Okay.
But those should be helpful. And I want to just put in a plug for Bonnie. She sees a lot of our patients. She's a great nutritionist, a great coach, really complete in her workup and recommendations. So I would say everybody should see Bonnie also.
Thank you. I appreciate that. Yeah, I think nutrition and lipedema go hand in hand, obviously.
Yeah.
It certainly worked for me, but I got to put in my plug for myself. And Tommy says thank you. So let me see if there's any other questions before we hang up. I don't see any more, so I'm going to let you go. But if somebody has questions, I will reach out, and they can reach out to Christina there to reach you. Thank you so much for joining us, everybody. I am so sorry that it doesn't appear that it was live on Instagram. I have no idea why it shows live on my end. So I'm not sure why, but I will post the replay so you'll get all the answers. And thank you to everybody who submitted questions. Great questions.
Yes, thank you, everybody.
Yes.
Happy to do this again.
Thank you for joining. Okay. I'm going to sign off here now.
Okay, me too. Bye-bye.